Sure. Well, thanks, Dr. Cohen. That was really an outstanding review of, what was heretofore, for me at least, a pretty complicated pathway of how these agents work, and I really appreciate the effort that went into that. So I'm going to try and review for you and our audience some of the data that we have for these JAK inhibitors for the treatment of ulcerative colitis as we move into this world of MABs to NIBs. As you mentioned, some of the early work that has been done in IBD has been with these two particular agents, Tofacitinib and Filgotinib. And Tofacitinib is the one that's pretty well studied at this point within the world of ulcerative colitis. Tofacitinib, as you mentioned, is an oral JAK inhibitor with specificity in theory and probably in reality for kinases 1 and 3. And it modulates the signaling of a large subset of pro-inflammatory cytokines by inhibiting JAK1 and JAK3. And these cytokines include IL-2, IL-4, 7, 9, 15, and 21. These are integral to lymphocyte activation, function, and proliferation. A phase 2 study of both safety and efficacy in patients with moderate to severe ulcerative colitis was performed. 194 patients in this study. It was demonstrated to show superior rates of clinical response, remission, and endoscopic remission, with a response rate of 70% in the highest dose group. These were all patients with moderate to severe UC. They were randomized to 4 Tofacitinib regimens or placebo twice daily over 8 weeks. And the measures that they used for response were a decrease of Mayo score of at least 3 points and a decrease in the rectal bleeding subscore of at least 1 point and an absolute subscore of 1 or 0 at the end of the study to count. And the statistical difference in these groups was really quite impressive. I think we'll have a figure up here about now that's going to show that it's a 78% clinical response rate for the group that received 15 milligrams twice daily over these 8 weeks, as compared to only a 41.7% response rate in the placebo group. There's really a very nice dose response curve that's present with the low dose of a 0.5 milligram twice daily, 3, 10, and 15, all showing an increase in with dose over time. Very, very nicely, a really nice looking figure that's there. And as you can see, statistical significance was achieved for that high dose, that comparison of 77.6% versus 41.7%. And you can also see that there was a real difference in the proportion of patients who were able to achieve a clinical remission using the Mayo indices. And again, the 10 milligram twice daily and the 15 milligram twice daily both showed impressive results and statistically significant advantage versus placebo, with greater than 40% in both of those arms receiving or achieving clinical remission compared to just 10% in the placebo arm. So ongoing phase 3 octave studies, which include not only the octave induction studies that have been done, octave induction 1 and 2, but the octave sustain study, as well as that long-term extension trial, which is octave open, were recently presented and show that there's really impressive really duration of effect over time. And this has been very, very encouraging, I think, and really adds to the notion that these could potentially be very, very successful therapies in the treatment of ulcerative colitis. Whether we're talking about mucosal healing endpoints or efficacy, and these were very impressively similar, both in anti-TNF treated and anti-TNF naive patients over time. And these are very impressive data, at least they seem so to me. As you can see in the induction 1 study, we have a 50 or 60% really clinical response rate compared to 33% for placebo, and similarly 55 versus 28.6 in the octave induction 2 study. These are really terrific studies. Unpublished data in the octave sustain study show that the proportion of patients in remission at week 52 which was the primary efficacy endpoint, was significantly greater both in the 5 milligram twice daily and 10 milligram twice daily studies when compared to placebo. And what's very interesting about this is that as opposed to the early 8-week study that I previously showed you, these are very nice data using the lower doses of 5 and 10 milligrams twice daily, really similar to what is out there for patients with rheumatoid arthritis in terms of dosing. So very impressive data over time, and really nice results, I think, for tofacitinib in the treatment of ulcerative colitis.
Dr. Ullman, one thing that you mentioned was on the SUSTAIN trial, which I don't believe has been published yet, but has been presented, is that while the 10 milligram twice a day group seemed to be the most effective in the induction for this agent, the tofacitinib in ulcerative colitis, for the maintenance, the 5 milligram twice a day did quite well too, which brings the possibility up of inducing with a higher dose, 10 milligrams twice a day, and then maintaining with 5 milligrams twice a day. And of course, it remains to be seen what doses get approved. In the rheumatoid arthritis current practice, they use the 5 milligrams twice a day, at least until recently too.
I also did want to point out that there is an ongoing study for Filgotinib in ulcerative colitis, the SELECTION trial, one of the longer acronyms that we've had to deal with here over time, and I won't go into the details of that acronym. But this is already in phase 2b and 3 clinical trial investigating the efficacy and safety of Filgotinib at 2 doses, 100 milligrams and 200 milligrams, and really with the usual kinds of endpoints and the usual kinds of design that's there. They're currently recruiting. The endpoint will be those, or the primary endpoint will be the proportion achieving remission at weeks 10 and week 58. And like you, I'm certainly looking forward to having these data presented to us. Perhaps Russ, Dr. Cohen, excuse me, we can spend a little bit of time and you can take us or guide us through some of the data that we've been able to see in the JAK inhibitors and their utility in Crohn's disease.
Well, Tom, I think you gave a really great summary for ulcerative colitis, particularly with tofacitinib, where we have a lot of information. And as I do recall the 2012 publication and the presentation of the data, and we were very excited to use this agent in Crohn's disease. The data with the Crohn's disease, though, was a little disappointing, although I really want people to understand one of the caveats, and that is that the placebo response rate was unusually high. So in the phase 2 study, which is, if you see pictorially, the blue bars are the placebo rates, you can see that the placebo response rate was 47.1% by the clinical response 70, which is a decrease in 70 points in the CDAI, which had been the standard since the biologics had been introduced for endpoints. So how do you beat a placebo rate of 47%? Well, the 5 milligram dose, as you can see by the bright yellow bars, were at 57.6%. But statistically, there really wasn't seen, if you look across all these endpoints, a dose response. The doses seem to kind of go up and down and maybe down, and who knows. And it took a little air out of our balloons, although it also made us wonder why, once again, the placebo response rate is trying to kill our Crohn's drugs. But what is important is that even though these endpoints didn't show statistical significant difference in dose response, if you looked at inflammatory markers, there was a big impact on that. And I think that's what has stimulated our interest in pursuing this agent further in Crohn's disease. More recently, there was just a publication looking at a phase 2b Tofacitinib Efficacy in Crohn's disease study, looking at the 10 milligram twice a day, 5 milligram twice a day, or placebo. I want to point out that the clinical response rate for placebo, if you look at the blue bars, was 55.6%. Again, which makes it difficult to, even though you have efficacy rates with the active drug around 70%, it's hard to show a big difference there. The remission rates in the 36.7% for placebo, slightly over 43% or 43% for the drug, and then going down the line. So the maintenance of remission perhaps was a little bit better. But it really perplexed why we're getting such a big placebo response rate. I think that tofacitinib's role in Crohn's disease, while it's still being studied, certainly isn't as advanced as for ulcerative colitis. And it may be because of differences between the conditions, but it also may be because the studies, the endpoints that we're required to use may not be very accurate in Crohn's disease, while they're more so in ulcerative colitis, which is also understandable because in ulcerative colitis, you can just stick a sigmoidoscope in someone and see if the mucosa looks normal at the end of the bowel or not, too. So for those of you who don't do IBD research, welcome to our world. It's very, very frustrating. However, I do want to point out that there was some more exciting information with the selective JAK inhibitor, the Filgotinib, in Crohn's disease. The Fitzroy study, which was published in 2017, showed that while the placebo response rate was 41%, the response rate for the drug was 59%, and remission rates were twice as high with the drug than with the placebo. So again, this is a selective JAK1 inhibitor. It looks certainly promising and certainly justifies doing further studies, certainly justifies doing further studies. Some people say, well, maybe the selective JAK1 is the way to go with Crohn's and the JAK1 and 3 is the way with ulcerative colitis. I would be a little hesitant to come to that conclusion until we get more data, because I still find it surprising that the tofacitinib, which works so well in ulcerative colitis, doesn't seem to have those numbers in Crohn's disease. I think it may be more of an outcomes in the studies than truth. So hopefully we'll be able to get one or both of these agents into the marketplace for one or both of those conditions. One of the parts of the Fitzroy study looking at Filgotinib and Crohn's disease compared the outcomes in patients who are anti-TNF treated versus anti-TNF naive. And you can see, just as in virtually any other study with the biologics or other agents, patients who previously had anti-TNF, shown in the bright yellow here, had lower rates of response and remission than those who are anti-TNF naive. And while it may be due to a change in the patient's environment as a result of the TNFs, or as we are learning now, maybe even a change in the microbiome, it also may be in some patients just the fact that they're tougher patients, and that's why they failed the TNFs or no longer on the TNF and eligible for the trial. But I do want to point out that the results in the anti-TNF treated are still quite impressive. Response in over 50% and clinical remission in over a third of the patients, which is quite good. Many of the other trials looking at anti-TNF experienced patients had noticed a huge drop-off in efficacy, and it's not as the case in this agent. And it may be, again, the issue of a small molecule versus a biologic. I don't think we know for sure, but certainly it'll be something to look forward to in other studies as well. Now, we have been talking about efficacy in ulcerative colitis and in Crohn's disease with tofacitinib and Filgotinib. One other area that clinicians and researchers and patients, of course, are very interested in is the safety data. So, Tom, can you tell us a little more about what we know so far about the safety of these JAK inhibitors in IBD or in other conditions?